how everyone is excited about type 1 diabetes management, and even we are running and rushing towards cure in type 1 diabetes.
Every quarter, every half year, we're seeing significant changes in type 1 diabetes. I would posit more than we used to see in the previous decade, when a change would take several years to come by. But what we are now beginning to see is treat the core cause of type 1 diabetes, the pathology of type 1 diabetes, and go towards insulin independence as best as we can. Let's not forget, India has the highest number of people under the age of 20 with type 1 diabetes in the world, and the second highest number of people with type 1 diabetes in the world after the United States. 90% of the people, 85 to 90% of the people that get type 1 diabetes do not have a family connection, do not, which means the general population can get type 1 diabetes.
Hello everyone, I'm Dr. Rutul Gokalani from the city of Ahmedabad. I'm a consultant diabetologist, and this is the second part of our previous D-Genius podcast, and it was on type 1 diabetes and exciting news. Today at EASD Vienna, we had one breakfast meeting of Breakthrough T1D, and it was clearly seen that how everyone is excited about type 1 diabetes management, and even we are running and rushing towards cure in type 1 diabetes. And today we have again with us Dr. Sanjoy Dutta, who is Chief Scientific Officer of Breakthrough T1D, previously which was known as JDRF. And so as we can see that it is becoming a field like oncology, where we are getting very closer to oncology kind of solutions. So, Dr. Sanjoy, how do you see type 1 diabetes management and cure in next 2 to 3 years, as we discussed again before 6 months, 8 months, I guess? What changes are there in last 6 months you are seeing, and what is new in type 1 diabetes management?
Thank you, first of all, for the invitation, Dr. Gokalani. I'm very happy to be here back with you all. Every quarter, every half year, we're seeing significant changes in type 1 diabetes. I would posit more than we used to see in the previous decade, when a change would take several years to come by. What I mean by that is that treatment modalities are definitely changing. HCP, all kind of healthcare providers, doctors, nurses, and allied healthcare professionals, their level of knowledge and competencies are improving a lot, which is helping the people with diabetes a lot. People with diabetes are much more knowledgeable, thanks to social media, thanks to internet access, and thanks to their appetite to learn more. And this knowledge is power. So I think these are the key things that are driving improved care, improved outcomes there. Of course, we have better treatments today. We have more accurate CGMs and pumps. We have integrated hybrid closed-loop systems, or also known as automated insulin delivery systems. There are better insulins coming on. And there's also other treatment modalities, though not regulatorily approved by in any country, but we are seeing increased off-label use with good outcomes of what we call adjunctive therapies. Besides that, you told me about the 6-month framework. We had 2 major diabetes meetings. I would say 3. We had ATTD, ADA, and EASD. I have seen remarkable advances in these 3. For example, we are seeing more and more data in cell replacement therapy. So this is a therapy where you take manufactured islet cells and put them back into a person with type 1 diabetes, mimicking donor-derived islet transplantation that has been successfully practiced for 35 plus years. We're seeing insulin independence coming out of it. That is a breakthrough. We're also seeing, beyond the approval of Tzield for what we call stage 2 type 1 diabetes, before one is put on insulin, we're seeing amazing results come out from multiple clinical trials in immunotherapy approaches, as well as beta cell therapy approaches in earlier stages of type 1 diabetes. Disease modification, changing the course of the disease. Remember, glucose control A1C management, insulin are very required, but they are a band-aid. They are treating the symptomatology of type 1 diabetes. But what we are now beginning to see is treat the core cause of type 1 diabetes, the pathology of type 1 diabetes, and go towards insulin independence as best as we can. And then finally, this awareness of the people with diabetes community, the medical community, and the whole ecosystem is allowing us to pursue early detection. Because if you don't know who is going to get the disease, how are you going to treat the disease? True. And so that's all. So this was a long answer, but there has been a lot of progress.
Wow. So the 6 months have been really exciting, and more thing we want to know in Indian perspective. So how do you see in Indian perspective, what could be relevant to India? Especially, let's assume we are getting T-Zild, government is going to support us for T-Zild, let's hope for the best. And if T-Zild is launched in India, what should we be prepared for?
Very, very good question, Dr. Gokalani. I really like that question very much. The first thing, and in beyond what I said about awareness, empowering patients and people with diabetes and their ecosystem there, I think early detection, identifying who is likely to develop the risk, we have very good tools. Last year, around June, we put out a monitoring guidance, and that has been accepted by 11 diabetes societies around the world. It was authored by people from 4 different or 5 different continents, 70 plus expert opinion there. Monitoring guidance is there, so clinicians know what to do. We had a meeting which Rutul, you attended also on this year. We had just came out with a screening consensus guidance, which we are hoping will be published by December of this year. So there is now methodologies, direction on how to identify this individual. So I think immediately what India can try and implement here, although I don't work in India and I don't follow the ecosystem there, I am from India originally. I think what can be implemented here is early detection. Let's not forget, India has the highest number of people under the age of 20 with type 1 diabetes in the world. And the second highest number of people with type 1 diabetes in the world after the United States. There is something India should do, and this can be implemented in the near term here. Then you asked the question about T-Zild, the only approved therapy for stage 2 diabetes. But I can tell you that is not the only one. There's going to be more approved therapies in stage 2 and definitely in stage 3 or recently diagnosed. Only if you screen, you identify these individuals, you can definitely make them benefit from the therapies there. T-Zild infusion will take infrastructure. It is a 14-day IV infusion, inpatient infusion. It'll take infrastructure. It'll take some cost. It'll take some knowledge. It'll take some practice. But it is not rocket science. Right. Medical professionals have been trained to do IV injections. It can be done. But you have to have the infrastructure to be able to sustain it for 14 days with the healthcare team, not with just one clinician here. Those are the things that I think can be done. And the third and final thing, let's not forget that of the millions of people living with type 1 diabetes, good glucose control is very much required to keep them healthy and happy so they can avail these curative treatments there. So immediately, I think enhancing your glucose control delivery, which includes best care devices and drugs, but also your delivery system, the interactive system. You did an amazing talk along with Dr. Day on AI-based, using this knowledge base to enhance what you can do today for glucose control. But don't lose sight of the fact that you have to think about where you need to be in 2 years, 3 years. Is that the time frame you gave me? In 3 years' time, have a robust screening program. And then, hope that T-Zild and other therapies will get approved in India, will be covered in India, be able to infuse them. Then it becomes a really good ecosystem of better treatments, even curative options coming out. So there's a lot that can be done in the 2 to 3 year time frame with the tools we have now. Yeah. And then if you're prepared for that, then you will be prepared for what's going to come beyond the 3 years, like cell replacement therapy and other therapies.
Right. So you're emphasizing more on screening program. So what exactly screening of, whom to screen, how to screen? Would you just explain briefly that today, as you were talking about, screening guidelines are coming or consensus coming out. So please explain.
Absolutely. Thank you again for the question here. I will give you the 60 or 90-second version, but I will encourage you all to read the publication when it comes out. Dr. Gokalani and others were at the meeting yesterday. They can give you more details on it. But in a minute's time, what I will tell you is who to screen. My immediate answer would be everyone and anyone to screen, because the incidence of type 1 diabetes today that we know of, although we don't have statistics around everywhere in the world, is 90% of the people, 85 to 90% of the people that get type 1 diabetes do not have a family connection, do not, which means the general population can get type 1 diabetes. Also, although if you have type 1 diabetes in the family already, which is only 10 to 15% of the current total T1D right now, the risk is 15-fold higher in another family member getting it. So two statistics you have to remember. 85 to 90% of the people that will get type 1 diabetes do not have a family member. So screen everyone and have a plan to do that, have an infrastructure to do that, have a cost structure to do that. But don't forget the families that have type 1 diabetes already, because a second family member in that family is 15-fold heightened risk compared to general population. So there are two pieces of math you have to kind of reconcile with, whether you start with family member screening first and then graduate to whole population screening, or right away go for the whole population screening. That's something the local economics people like you and other experts will have to work out in India. And I'm happy to help from a Breakthrough T1D perspective for the support we can provide.
Wow, great. So again, question on screening, that how to screen. So, and what we screen with. I know the antibodies, but as you know, even in India, the already diagnosed type 1 kids, they are not even screened for antibodies. So you emphasize on screening with antibodies mainly, or anything else also?
Right now, what we have the most data on is autoantibodies are a precursor to the development of insulin requiring type 1 diabetes. Autoantibodies, when you have them in your blood, is stage 1 and stage 2. And then when you go further progress, you go to stage 3 when you require insulin. Based on that tenet, I would say that autoantibody screening is the proven tool we have now. And so how to screen is screen for autoantibodies. It is actually quite dangerous, and I'm using the word cautiously here, quite dangerous to consider somebody a type 1 person with type 1 diabetes based on other parameters like, oh, you're young, so you're a person with type 1 diabetes. You're lean, so you're a person with type 1 diabetes. Oh, you're above 25, 35, 40 years of age, so you're type 2 diabetes. That is a myth, and that is a medical mistake, I would say. And we have lived through that because, again, up to, and I'm throwing a lot of stats at you, so, but please go back and remember the stats here. Up to 44% of adults are misdiagnosed with type 2 diabetes first, treated for 8-10 years with metformin. They don't do any, they don't do well. They progress further down, and the moment they put on insulin, they start doing well. They are people with type 1 diabetes. So 44% were misdiagnosed in adulthood. In childhood, it's obviously lower, but let's not forget that there are many children and adolescents, mostly adolescents now, at least in the United States, getting type 2 diabetes. So it's an important distinction for us to use medical tools to diagnose people, and not, common sense will always prevail, but not base it just on that, because yes, 10 years ago we didn't have the tools, but we have the tools now. So it would be almost like a mistake, medical mistake, to not be using them. So I would do autoantibody screening now.
So which antibodies?
So there are four. There are about 7 or 8 autoantibodies, but the 4 bona fide autoantibodies that are routinely screened are insulin autoantibody, insulin islet-like autoantibody, zinc transporter T8, and GAD, which is glutamate acid decarboxylase antibody. Right. These are seen. You don't have to have all the 4 autoantibodies, but when we say you have 2 or more autoantibodies, your risk level goes up. And then as the risk goes, as you progress through the disease, then you start losing your insulin production or your beta cells in your pancreas. And then although you don't need insulin because you have a threshold of beta cells, you start showing dysglycemia. You fail an oral glucose tolerance test. Your postprandial 2-hour glucose is much more elevated, which is showing signs of insulin insufficiency, but not enough to put you on insulin. But any chronic disease progresses further if you don't treat them. And then finally, you reach a threshold when you really need exogenous insulin to be able to manage your glucose levels or your meals here. So I would screen for all 4 autoantibodies. There's a lot of literature around in children which autoantibody tends to come out first and is more aggressive, like IA versus GAD coming on later in life. But all those data is based on a Caucasian population and Caucasian genetics here. So in India, I would suggest that start with all the 4 autoantibodies there. Again, infrastructure, cost, methodology, knowledge, all of those things will be required to be successful here. That's what I would do. And then as you get positive, then introduce glucose tolerance test. If you can implement CGM, it's a very powerful tool. It's a very powerful tool, CGM. It gives you even more data point than a 6-month OGTT.
And so even in the screening phase, we
have a lot of publications. Yes, there's a lot of publications. There's a lot of publications. We have supported a lot of research. We and others have a lot of research in using CGM in stage 2 type 1 diabetes, or in fewer cases in stage 1, because CGM is a more sensitive marker. But we don't really have all the thresholds right now. And you're going to get real-time reading rather than bringing somebody in your clinic every 6 months to give them a gooey drink and do a 2-hour OGTT. Nobody likes it, let alone kids. And so, but if you have a CGM, which I know comes with burden and cost also, you will be getting more real-time data, and you can intervene much earlier than waiting for 6 months for the next 6 months or 1 year for the next CGM OGTT readout.
Wow. So yeah. Thank you very much for such a elaborated answer, and we got almost everything what we should get prepared for and in next 2 to 3 years. But one more question, which is very much relevant, that what is the hope for type 1 diabetes and what we need to be concerned for in type 1 diabetes?
Hope, there is a lot. There's a lot of hope here. I don't want to be Pollyanna, but I've been in this line of work for a long time here. And I will say, and I've said this many times, the amount of innovation and success I've seen in the last 5, 6, 7 years, ever since the closed loop system started coming out, immunotherapy, data with cell replacement therapy, I hadn't seen in the first 20 years of my career. And that doesn't mean the first 20 years of mine and other people's careers were not useful. We were laying the foundational knowledge. What is type 1 diabetes? Who gets it? What are the genetics? So, and that 20 years of basic science work has now really helped us to leapfrog into these inventions and discoveries and approvals and therapies and everything else out there. So I have hope that if we went at, and I'm going to use an analogy here, so bear with me here, if we were going at 30 miles an hour in the first 20 years, we're now going at 60 miles an hour, and I would posit that we will be going at 80, 90 miles an hour. I'm from the US, so I'm using miles an hour, so I apologize, but you can do your conversion. Caution here is that there is a huge need for public awareness, both healthcare provider and the people and the family awareness. That education component is going to become very, very, very important, because knowledge is power, both from the provider end and the receiver end here. That is going to take a lot of work, will take a lot of advocacy work, will take a lot of federal support, and certainly a lot of support from folks like you and others there. That's one challenge, and then the other, and there are many other areas of not insurmountable, but many other areas of concern, challenge that one has to be aware of, is what I kept saying many times, is infrastructure, because you might have everything available there, but if you don't have the infrastructure to implement it, if you don't make it easy for the people with diabetes, if you don't make it easy for the provider, because you guys have probably, what, 400 patients, more than that, 500 patients to look at, then the system will break, it'll crash. True. It's like overloading an operating system, it's going to crash. So if you don't have the proper RAM, it's going to crash. And so I would say knowledge, awareness, education, all those in one bucket, and the other is building of infrastructure. So when the tools are at your hand, they are at the bedside.
Great.
I hope that was helpful.
Yeah, yeah. So one last question, and important question, as I heard you in India when you were there in February, I guess,
Yeah.
and you were talking about one of the device made in India in Bangalore, IIT Bangalore, I guess, and we are excited.
small
as
biotech company, yeah.
Yeah, it may come up with good pricing for insulin pump. So what is the progress?
Yeah, I was not prepared for this question. I'm sorry because I don't manage the
device.
grant. No, I don't manage the grants or the thing, and that's my lack of knowledge here. I apologize to the audience here, but my colleagues do. They report to me, but they do manage those things. So I don't have the latest progress, but I haven't heard anything that is negative. So no news is good news. I think they're meeting their timelines. They're making the progress. I can't give you the latest because I just didn't get the update now.
Right.
But if I haven't heard anything, it means it's progressing well. That's usually a good moniker of how things are going, and that's how I keep track of the 400 plus grants that we fund annually. Yeah, we have a portfolio of over 400 grants here: industry, academic, clinical, basic, devices, drugs, everything. Put together, it's 400 plus grants that's active at any point in time. And so I think they're progressing well. I like their creativity. I like, most importantly, their mission is to provide solution at a cost-effective rate for countries that need it at a cost-effective rate. Will it be the slickest pump that we have in some of the other countries? No, but it's better to have a pump than not have one at all. At least as a starting point, and that's where I would say that they're making very good progress.
Great.
Spun out of IISC Bangalore, and now into a small biotech company as well.
Oh, so no news is the good news. This is what we are hoping for. And
so from my end,
yeah.
But in type 1 diabetes, is always good news coming out.
Great. So for Indian perspective, we have heard a lot of things that what we need to do, and we are also very much hopeful, and we really hope to work closely with Breakthrough T1D in next coming years. And thank you very much, Dr. Sanjoy Dutta, for sparing time again and again. We are so happy to.
The pleasure is all mine. Thank you, Dr. Gokalani. Thank you to the audience here, and let's stay in touch.